Met the next speaker. He was a registered nurse, very interested in medical cannabis, and he went from there to being the man. I'm telling you this right out, face to face. He's the guy that got post-traumatic stress into the New Mexico law. He's a friend of mine. He's on the board of advisors of Patients at a Time. Please welcome Brian Crum.
Hi, I'm Brian Crum. I'm a psychiatric nurse practitioner in Albuquerque, New Mexico. I work at Sage Neuroscience Center. So Chris had just gone over the diagnostic criteria for PTSD, so I'm going to skip my first couple of pages here. PTSD is considered the fourth most common psychiatric disorder, affecting 10% of all men and 18% of women, with rates closer to 40% in high trauma populations such as combat and low-income inner-city populations. Originally, PTSD was considered a normative response, related primarily to stressor intensity. It's now clear that the response of an individual to trauma depends not only on stressor characteristics, but also on neurobiological factors related to the specific individual. PTSD often occurs comorbidly with other disorders, such as depression, substance abuse, and other anxiety disorders. Chris went over the three predominant symptom clusters in PTSD, which are re-experiencing symptoms, avoidance symptoms, and hyperarousal symptoms. Because of the broad range of symptoms we see in PTSD, it's often difficult to treat with a single medication. This often leads to the use of drug cocktails, which can cause significant adverse effects. Cannabis addresses symptoms across all three major symptom clusters in PTSD and does so with few clinically significant adverse effects. Raphael Mechoulam, probably the world's foremost authority on cannabinoids and the endocannabinoid system, has pointed out, it has been suggested that pharmacological treatments in psychiatry have been overly reliant on neurotransmitter systems and their agonists. In the last several decades, advances in psychopharmacology have reduced side effects but have failed to lead to major disease improvement. The endocannabinoid system may shed new light on the physiological basis of psychiatric diseases, leading to new and more effective treatments. And that's a direct quote from Raphael Mechoulam. In order to properly treat PTSD, we need to understand the underlying neurobiological processes involved in its etiology. PTSD is increasingly understood to involve central neurotransmitter imbalances and neuroanatomical disruptions, along with potential dysregulation of immune, autonomic, endocrine, and cardiovascular function. PTSD is associated with dysfunction in the amygdala, the anterior cingulate cortex, the medial prefrontal cortex, and the hippocampus. We see possible structural impairments in PTSD, including decreased hippocampal volume, which likely precedes PTSD and predisposes a person to developing PTSD symptoms. We also see decreased anterior cingulate cortex volume, which likely follows the development of PTSD. The neurocircuitry model of PTSD emphasizes the role of dysregulation and threat-related processing. Trauma exposure sets off a cascade of neural changes, leading to a state of amygdala hyperresponsivity, triggering hyperarousal and vigilance. Inadequate top-down control by the medial prefrontal cortex and anterior cingulate cortex perpetuate the state of amygdala hyperresponsivity, leading to increased attention to trauma-related stimuli. The hypothalamic pituitary adrenal axis is the central coordinator of neuroendocrine stress response systems, and as such, it has been a major focus of scrutiny in patients with PTSD. Upon exposure to stress, neurons in the hypothalamic paraventricular nucleus, or PVN, secrete corticotropin-releasing hormone, which stimulates the production and release of adrenocorticotropin from the pituitary. The adrenocorticotropin then stimulates the release of glucocorticoids from the adrenal cortex, which modulates metabolism, immune function, and brain function to manage stressors. Sustained glucocorticoid exposure leads to reduced dendritic branching, loss of dendritic spines, and impaired neurogenesis of the hippocampus. Cannabinoids have a profound effect on the function of the amygdala, and endocannabinoids are crucial for the extinction of aversive memories. Activation of CB1 receptors in the amygdala blocks reconsolidation of aversive memories. This suggests that cannabinoids could be useful for the treatment of patients with PTSD because they may be less likely to relapse after a stressful experience. THC has a significant and selective impact on amygdala reactivity to signals of threats in humans. The endocannabinoid system plays a significant role in the function of the prefrontal cortex as well. The prefrontal cortex is highly interconnected with the rest of the brain, which allows it to receive and modulate information processing in other regions. The prefrontal cortex projects to subcortical arousal systems, regulating monoamine and cholinergic inputs throughout the brain. Activation of cannabinoid receptors in the medial prefrontal cortex elicits potent antidepressant-like behavior and enhances 5-HT neurotransmission. The antidepressant activity of cannabinoids likely involves disinhibition of excitatory projections from the medial prefrontal cortex to serotonergic neurons in the dorsal raphe. It appears that CB1 receptors are involved in not only the extinction of conditioned fear, but also in the adaptation to aversive situations in general. Enhancing the endocannabinoid system could be a new mechanism for medicines to alleviate depression and related psychiatric disorders. Cannabinoids have diverse effects on hippocampal memory and plasticity. There's a general consensus that the effects of cannabinoid agonists on anxiety appear to be biphasic, with low doses being anxiolytic and high doses possibly being ineffective or possibly angiogenic. However, chronic high dose of cannabinoids has been shown to induce hippocampal neurogenesis. And this hippocampal neurogenesis appears to at least lie part of the underlying mechanism for the anxiolytic and antidepressant effects that we see with high-dose chronic cannabinoid treatment. Modulation of hippocampal memory and plasticity by targeting the endocannabinoid system may aid in the treatment of impaired extinction-like processes seen in PTSD. The endocannabinoid system also plays a critical role in the regulation of the HPA axis. Endocannabinoid signaling negatively modulates function of the HPA axis in a context-dependent manner. Short-term activation of the HPA axis is beneficial to the survival of the organism. However, long-term activation can impact metabolism, mood, and cognition, and is associated with a variety of neuropsychiatric disorders. Cannabinoids, through action on both limbic and paralimbic brain areas, reduce activity of the amygdala and the hypothalamus. Retrograde endocannabinoid signaling in the hypothalamus is responsible for regulating HPA output. Acute administration of exogenous cannabinoid ligands also activates the HPA axis indirectly through an increase in both serotonergic and noradrenergic neurotransmission. Chronic exposure to dicipramine and perhaps other antidepressant drugs and therapies has been shown to upregulate the endocannabinoid system, which in turn dampens the stress axis in a manner similar to habituation. Endogenous cannabinoid signaling is essential for stress adaptation and is a fundamental part of the intrinsic regulation of the HPA axis. I picked 4 case studies, hopefully to kind of give a broad range of the types of patients that we might see PTSD in. The first one is a male in his mid-20s. He was diagnosed with PTSD, profound autism, intermittent explosive disorder. He had been through multiple medication trials. When he came to me, he was on high doses of Risperdal, clonidine. He had also been chemically castrated with doses of Depo-Provera that he was being given every other week instead of every month like he was supposed to. We immediately started to decrease the use of some of the other medications. He was having significant akathisia from the Risperdal. We brought down that. He had been having significant constipation, which of course he was non-communicative, so he couldn't tell us the discomfort that he would have with constipation. I started him on hemp seed protein powder, the high fiber type. In traditional Chinese medicine, that's used as a treatment for constipation. In my own practice, I have found that to be the best thing for treating constipation, especially with patients who have it be related to opioid use. Once we got him down on the Risperdal, stopped the Depo-Provera, we started seeing some increased sexual acting out. I started a PRN dose of dronabinol with him, 2.5 milligrams. He had a good response to the dronabinol, so we put in place 2.5 milligrams of dronabinol routinely. And we started backing down again on the other medications. We referred him into the medical cannabis program because of the PTSD, which, because of being nonverbal, we had to work through both family and staff members, treatment team members to make that determination that he did indeed suffer from PTSD. It was based on just an analysis of the type of behaviors that he would express and when those would come up. He experienced significant benefits with the dronabinol. We have him on some other dietary supplements, magnesium as well. He is now in the medical cannabis program. On weekends when he is at home with his parents, he gets cannabis butter and a set dose, and he continues to take dronabinol in the group home setting. He's off all his other medications except for the dietary supplements and the dronabinol and the medical cannabis, and he's doing very well. Severe aggressive behaviors have dropped from almost every day to almost nil. He's better able to transition between activities. The second patient is a female in her early 20s diagnosed with PTSD, bipolar II disorder, and ADD. She had been through multiple medications also. She came to me after she had been discharged from her previous psychiatrist because she was using marijuana. And he thought that was the root cause of all her problems and told her if she couldn't stop using marijuana, he was dropping her from treatment, dropped her off all her medications. She decompensated, came to me acutely suicidal with bad mood swings, irritability, anger. She was using cannabis occasionally, getting some benefit, but her symptoms weren't well managed. I put her on some Abilify. That helped manage her mood swings, but she was still having depression and anxiety. We put her on a little bit of Wellbutrin, a little bit of Klonopin. She started doing better, got her in the medical cannabis program. A few months into that, she told me that she had taken herself off all her other medications. She did very well in the medical cannabis program as monotherapy for many months until the Department of Health did not renew her medical cannabis card. They had a delay of like 4 months on these medical cannabis cards, during which time she lost access to her medication. She decompensated, became more manic, started using alcohol, put herself in dangerous situations, and she ended up being traumatized again. We've got her back in the medical cannabis program now. She is back in therapy and she's starting to do better. My third case study is a male in his mid-50s diagnosed with PTSD, chronic and paranoid schizophrenia. He had been through a slew of medications before coming to see me. He had a history of very poor medication compliance, poor treatment compliance. Medications just would not manage his symptoms. When he came to me, he was having severe auditory hallucinations with commands to kill himself and others, including when he would hold his grandchild, he would have command hallucinations to kill his grandchild. It was terrifying for this gentleman. We initiated again traditional antipsychotic medications, antidepressants, anxiolytics, trying to manage these symptoms, and we got nowhere. Eventually, I was able to determine that he was suffering from PTSD as well, related to the experiences of living with chronic mental illness, with chronic paranoid schizophrenia. Just that alone is enough to have a traumatic impact on somebody's life sometimes. Put him in the medical cannabis program. He gained immediate relief, a reduction in both the positive and negative symptoms of schizophrenia. He's using the cannabis routinely now, has good access to it. He still hears occasional voices, but he doesn't hear command hallucinations anymore. He still sees occasional visual hallucinations, but they're shadows, they aren't demons. And he is able to enjoy time with his family. He can hold his grandchildren and love his grandchildren. It's an amazing change to see. My fourth case study is a male in his mid-60s. He's a Vietnam vet diagnosed with PTSD. He had multiple injuries in Vietnam. He had multiple surgeries because of these injuries, and he had multiple failures of these surgeries. He has been on pain meds for long-term. He had also been on long-term use of psych meds. He came to me because his liver was destroyed by the pain medications and the psych meds, and he wanted an alternative. He had started using cannabis occasionally, found it to be very effective in alleviating his symptoms, so we referred him into the medical cannabis program. Cannabis stops the nightmares, it keeps his mood stable, decreases the irritability, the anger. He still gets anxious when he goes out in social situations, but he's able to manage that and actually get out and have a life. It's made a huge difference for him. He's off all his opioid pain medications now, and he's off all his other psychiatric medications. I currently manage hundreds of PTSD patients in New Mexico's medical cannabis program. And when I say hundreds, it's probably closer to 1,000. Most of these patients have other co-occurring psychiatric and/or medical issues which contribute to their symptoms. There is evidence that the endocannabinoid system is involved in the extinction of aversive memories, and PTSD patients claim that cannabis use helps them considerably. The stimulation of cannabinoid receptors in the prefrontal cortex, amygdala, and hippocampus with the subsequent activation of different signaling pathways appears to be the first event underlying the effects of cannabinoids on anxious states. THC appears to prevent activation of this anxiety circuit. Changes in levels of CB1 receptors and endogenous CB1 ligands are observed in depression. Stimulation of cannabinoid receptors enhances stress coping behaviors and increases spontaneous firing of serotonergic and noradrenergic neurons in the midbrain. Phytocannabinoids, including THC, CBD, and CBC, exert antidepressant actions. The CB1 receptor is an important new target in the development of antidepressant drugs. High rates of suicidal behavior have been found among PTSD patients. Sensitization of CB1 receptor-mediated G protein signaling in the prefrontal cortex is one of the neuroadaptive factors in the pathophysiology of suicide and likely contributes to suicidal behavior. The role of the endocannabinoid system in the pathophysiology of PTSD suggests that cannabinoids may be an effective modality not only to treat PTSD, but also suicidal behavior in persons with PTSD. Inhaled cannabis is generally well tolerated and has been shown to reduce the intensity of pain, decrease anxiety, and improve sleep. Cannabinoids may reduce or entirely eliminate nightmares, and patients using cannabinoids report improvement in sleep time, quality of sleep, reduction of daytime flashbacks, and night sweats. Alcohol use has been significantly linked to PTSD, and cannabis has been shown to reduce and act as a substitute for alcohol. The majority of patients I have referred into the medical cannabis program who use alcohol have reported significantly decreased use and in many cases complete cessation from alcohol. Cannabinoids have been shown to reduce aggressive behavior, which has a huge impact in PTSD. Many of my patients report significant reductions in irritability and anger. Oftentimes, patients are accompanied by family members, friends, and/or treatment team members who confirm reductions in aggressive behavior. I have a significant number of patients who use cannabis for PTSD who have co-occurring psychotic disorders. Although the use of cannabis in schizophrenia has typically been reported to worsen psychosis, increases in population cannabis use have not been followed by increases in psychotic incidence. Dronabinol, synthetic THC, has been shown to improve symptoms in treatment-refractory schizophrenic patients, including reductions in core psychotic symptoms with no clinically significant adverse effects. Schizophrenic patients who use cannabis and patients with a history of cannabis at first episode of psychosis have superior neuropsychological functioning compared with non-using patients. I've seen consistent benefits from cannabis in reducing both positive and negative symptoms of schizophrenia with few adverse effects. Using strains of cannabis containing CBD in addition to THC may be protective against the psychotic-like symptoms that may be induced by THC alone in some individuals. A comprehensive study of 4 legal medical cannabis patients in the Federal Investigational New Drug Program found only mild changes in pulmonary function associated with long-term heavy use. That study was actually conducted by patients out of time. It's the only study that has ever been conducted on patients in the Federal Investigational New Drug Program. No functionally significant adverse effects were noted in any other physiological system studied. Cannabis is proven to be the safest, the best tolerated, and most consistently beneficial medication available to help my patients with PTSD. Most of my medical cannabis patients have been able to decrease the use of other medications after beginning medical cannabis, and in some cases they have eliminated other medications entirely. Fewer than 1% of the patients I've referred into the medical cannabis program have reported stopping because of adverse effects. The most commonly reported adverse effects are mild anxiety or mild paranoia. The vast majority of my patients who do experience occasional adverse effects report that the benefits of cannabis outweigh the risk, and they choose to continue treatment with cannabis while avoiding those particular strains which are more likely to cause those adverse effects. The most common reasons reported for discontinuing treatment with cannabis are employer-related drug testing, high costs of the medication, and the stigma associated with cannabis use. So in conclusion, cannabis is a safe and effective medication for treating PTSD, even when we have other co-occurring psychiatric disorders. The broad range of therapeutic effects seen with cannabis in treating PTSD suggests it would be an ideal treatment for many psychiatric disorders. Rather than simply targeting neurotransmitter systems and their agonists the way we do with current psychiatric medications, cannabinoids target the underlying neurobiological processes that lead to imbalances in these neurotransmitter systems, helping to return them to a state of homeostasis. Unfortunately, poor access to cannabis may place medical cannabis patients at risk for decompensation if they're unable to maintain a consistent and safe supply of their medication. As medical providers, we have an obligation to our patients to be aware of the therapeutic value of cannabis and to provide the best possible care based on the best available scientific evidence. We also need to take a more critical look and play a more active role in demanding access to this medication in order to assure the safety of our patients. We have a lot of things that we as providers in medical cannabis states are able to do. The big argument that the government makes when they say that we can't have medical cannabis is they say that we don't have the FDA-approved controlled clinical studies to show that cannabis is safe and effective. What we do have are 16 state laboratories with hundreds of thousands of active patients, all of whom are using cannabis, and data can be collected on, and we can generate the research. We don't need the controlled clinical trials approved through the FDA that are going to be denied by NIDA and the NIH. We have this already. As providers, we have the ability to make a change in this. I know that my presentation wasn't in the board for some reason. It is in your syllabus, but it doesn't have the references. If any of you would like a copy of my presentation that does have the references included in that, you can email me at reeferdoc@hotmail.com. So it should be fairly easy to remember. Thank you very much. Since Al's not here, any questions? While we wait, yes. Well, it depends on the patient. She asked me how often I follow up with my patients. And I said it depends on the patient. For some of my patients who may be on other medications who have more active symptoms, I follow up at least generally on a monthly basis with a lot of my patients. Once people start to stabilize, we stretch those appointments out to 2 months, 3 months. For patients who are doing well and are fairly stable on medications, I do require that they follow up with me at least every 6 months to maintain these people as an active patient. We can follow the progress with the cannabis, and it has to be renewed on a yearly basis. But probably most of my patients I follow up with monthly initially, some of them even as often as weekly and every 2 weeks, just until they become more stable. Yes? Every state, okay, she's asking about what these 16 state laboratories are. The 16 state laboratories are the 16 states that allow medical use of cannabis. These are statewide laboratories, and anybody who is referring patients into these programs has the ability to collect data and publish those results. I think I am out of time, so I am going to allow Al back up. Thank you very much.